I'm Gary Palmer. I'm running for Congress for the Alabama 6th District. And in the course of my campaign, one of the key parts of this is healthcare reform. I've talked with people around the state and around the country about what we need to do, and I'm seeking out people who have expertise in terms of the real delivery of healthcare. And that's why today I wanted to talk to Dr. Jeff Davis, who's an orthopedic surgeon. And Dr. Davis, I appreciate you talking with me. I want you to tell the viewers who you are and what you do.
I appreciate it, Gary. Thank you very much. My name is Jeff Davis. I'm an orthopedic surgeon here at Andrews Sports Medicine at St. Vincent's Hospital in Birmingham, Alabama. I've been in practice for 20 years here in the city of Birmingham. And before that, I was in 4 years as an orthopedic surgeon in the Air Force, serving in Spokane, Washington. My educational background is I was born in Alabama, North Alabama, in Decatur, raised in Atlanta. I went to Georgia Tech as an undergraduate, and then I went to Medical College of Georgia for medical school, and then did my orthopedic training in Memphis at Campbell Clinic, University of Tennessee at Memphis. And then, like I said, I've been in practice here at both Alabama Sports Medicine and Andrews Sports Medicine for 20 years here in Birmingham.
Well, Dr. Davis, I know there's a lot of issues impacting healthcare, and I think this is one of the biggest challenges that we're going to have over the next 3 or 4 years is what we're going to do about Obamacare, the Affordable Care Act. And on the campaign trail, I'm telling people that we will repeal it and we're going to replace it. But it's going to take 3 or 4 years, obviously, with President Obama being in office for 2 more years. It's not likely that we'll get it repealed in the next 2 years. But talk a little bit about how it's impacting your practice.
Well, I think that the Obamacare, particularly, it was a law that was written it had a good initial idea, the concept of trying to get uninsured people into the system, which I don't think anybody has a problem with. But then it was kind of taken over by special interests, and everybody got a little piece of it, and it created this monstrosity and a lot of unintended consequences. And the law ended up being passed by people that never read the law. And now those unintended consequences are coming home to roost. What we're seeing is increased costs associated with it, unfunded mandates. We're being taxed as providers to pay for this. The medical device companies are being taxed, which is decreasing innovation, stifling innovation, which has been a linchpin of our medical industry in this country. We've always been leaders in that, and that's kind of going away a little bit. We're losing some of our research edge. What we're seeing is more and more patients are having higher and higher insurance premiums. They're being shifted to more out-of-pocket expenses for themselves. They're not being able to afford care when they need it. They're having to postpone or avoid treatments that they need for their health care. So we're seeing a lot of things that the negative consequences. And then in our practices as businessmen, we're small business owners for the most part. What we're seeing is a lot of unfunded mandates. We're seeing a lot of increased expense associated with this act that's causing us increased costs, and the reimbursements are not going up. In fact, they're declining for Medicare. For most of us, they're declining. So it's creating an undue burden, and many physicians now are choosing to become employees rather than small business owners. And what that means for patients down the road is that instead of being a private practice, hustling, working individual, you become an employee, and you don't have that same kind of desire to succeed and push yourself, because you're an employee for somebody else. You're not working for yourself and for your patients.
Well, you talked about all the unfunded mandates. I think most voters, most people around the country are unaware that aside from the Affordable Care Act, Obamacare, that there's another mandate that the federal government was trying to impose upon you. It was called ICD10, International Classification of Diagnosis, and that doctors' practices all over the country are being forced to install new software, new computer equipment, and they're being told that if they miscode something, that that involves Medicare, Medicaid, maybe even a third-party payer like a health insurance company, they could go as long as 6 months without getting paid. That was supposed to be implemented October 1st of this year. It's been postponed another year, but that's an area where I've also been focused in working to try to get that eliminated. I don't think there's another country in the world that ties payment to coding, and I think it's going to result not only in higher costs for healthcare, but more of what you're talking about, shutting down the smaller medical practices, forcing doctors out of medicine or into bureaucratic practices, the huge corporate practice where you're just an employee and you put in your hours basically.
Right.
And instead of hustling, as you say, to provide the best health care you can and competing for patients, it's going to limit patient access, it's going to limit patient choice. But I'm very concerned about how it's going to impact rural areas. I think that we're going to see rural hospitals shut down, rural practices close, and for instance, my mom lives in Hackleburg. The closest hospital to her is 15 miles away. The next closest is 18, and I guarantee you that 95% plus of their patients are Medicaid or Medicare, right. And they just can't handle this. Do you see that going on around here now?
We saw there's kind of a panic mode with practices realizing that the ICD-10 was going to happen, and one of the problems with dealing with the government is they keep saying things are going to happen, and they keep moving the finish line with many things, and so it's hard to know when they're being serious that something's going to happen versus not. But we were told up until March of this year that this was going to happen. October 1 was the drop dead date for ICD-10 coming, and that the cost of implementing that for practices was in the tens of thousands of dollars, and for some larger practices it's hundreds of thousands of dollars, and for hospitals it was in the millions of dollars. And so for, like you said, rural hospitals and rural practitioners, especially solo practitioners trying to run a practice out in the rural communities, it was going to be unaffordable. Their margins are already very, very small because of the reimbursement. So it was going to impact them significantly. And now it's been postponed for a year, but they're still saying it's going to happen. So there's still a huge concern about that coming down the road.
Well, if elected to Congress, that's going to be a top priority for me because you take ICD-10 and you take Obamacare, and what you're doing is you're making medicine a corporate enterprise or a government enterprise. And in both cases versus private practice, the incentives change. And I've tried to explain this to people. They say, well, what's the biggest thing about a government-run healthcare system versus a private practice? Well, in private practice, your number one priority is the outcome of the patient, because you want them to go out and tell their friends and family if you've got an issue, if it's an orthopedic need, you want them to tell their friends and neighbors, go see Dr. Davis because he did a great job. But that's how you build up a practice. But in a government-run system or a corporate system, the number one objective is cost control. Right. And they're looking at every opportunity they can to cap the cost. We saw this happen in Canada in one of their provinces where they literally ran out of money 3 months before the fiscal year ended. So there's a huge difference, and I was explaining to someone else, they were focused on the cost of Obamacare. I said, the cost is not the big issue. I said, 10 years from now, you'll find out what the real issue is because of how they want to cap things. You'll go into your doctor, he'll tell you need an MRI. You'll go down to get the MRI, and they'll tell you, Mr. Smith or Mrs. Jones, come back in 8 weeks. And then when you come back in 8 weeks, they'll say, well, it'll be 2 more weeks. Whereas if you go in and see a doctor now and they tell you need an MRI, if you see them in the morning, that afternoon you've had your MRI. It's going to be access to the diagnostic care. That's why in the United Kingdom and Great Britain, the mortality rates for prostate cancer and breast cancer are so much higher than they are here because those people don't have access to the early diagnostics.
Well, in orthopedics in those countries too, there's long waits for if somebody comes to see me with a bad hip or a bad knee, and once we've decided that they're medically appropriate to be done, it's not a problem to get them on the schedule and get them done. Whereas in those countries, the wait can be up for 2 years before you can get something done. So, I mean, the patients are in misery for 2 years waiting on getting the procedure done. And then if they run out of money, maybe even longer than that, because as you said, it's based on economic, not medical needs.
Well, in talking with doctors, I like for them to ask me questions because I try to listen, and I'm a solutions-oriented guy, so I need to know from your perspective what the issues are, and then give me an opportunity to articulate some solutions, or at least go back and think about what we need to do and come up with a solution.
Well, I think for us, we talked about some of the problems from a regulation standpoint. For me as a practitioner, I think two of the things that we have not discussed so far is number one, the Medicare problem, the SGR, and the flawed formula that they use to reimburse us. Everyone admits that it's flawed, but yet they keep doing a patchwork every year to change it, and it needs to be corrected so that we have some idea going forward that it's going to be consistent. The second thing I see is that while you mentioned that right now if you came to see me and got an MRI, if you wanted an MRI, we agreed that you needed an MRI, it was pretty easy to do. That's becoming increasingly more difficult as more and more insurers, and Medicare really hasn't done that yet, but more and more insurers are putting a lot of people in between the patient and I to make those decisions for us, that we're not able to, just the two of us, make those decisions, so we lose some autonomy, and I think that that's a problem in this country going forward. So for me, those are two big issues.
Well, you're addressing what I think is the biggest issue with Obamacare, and that is the bureaucratic red tape and the impediments between physician-patient relationships. As a guy who's worked with a think tank for 25 years, we tend to talk about it in the context of bringing market principles into medicine. And when you talk about market principles, you look at medicine as a deliverable, or healthcare as a deliverable. It's a product, and people want to get the best product at the best price with the best result that they can. But when you've got these various layers of third and I think possibly fourth level or fourth party intermediaries that are you not only increase the inefficiencies, but you basically block that patient-physician relationship. It all becomes a cost containment issue, and I think what we're going to have to do is we're going to have comprehensive reform, and we're going to have to do it incrementally. People ask me if there's anything about Obamacare that I'd leave in, and I would. I think we do need to require coverage for pre-existing conditions, but we've got to do it in a way that makes sense financially and economically. But I'm going to start on the young end, which is unless it's a sports-related injury, it's not primarily the big part of your practice. You're going to be on the back end with knee replacements and hip replacements and that sort of thing. But on the front end, when they were pushing Obamacare, they were talking about all these young people who were uninsured. But what they didn't tell you is that they chose to be uninsured, because you take somebody 22 to 30 years old, it doesn't make sense to them to pay $200, $300, $400 a month for an insurance premium that they don't think they'll ever use. They rarely go to the doctor. They think they're indestructible. They don't get sick. And so that from just an individual perspective, they'd rather put that money in their pocket. What we will do when we replace Obamacare is we will dramatically expand health savings accounts, so that a young person graduates from college, they get their first job, they can if they want to, they can enroll in their employer plan, and their employer can provide a health savings account where instead of putting $300 or $400 a month into a health insurance plan, they'll buy a major medical plan that has, let's say, a $5,000 deductible, and then that $400 a month that would have gone toward a health insurance premium will go into that health savings account, and it's their money. They get the same tax treatment they would have if they were buying insurance, but what they don't spend, they keep. So if you've got say you've got $5,000 in your health savings account, and you spend $500, that $4,500 rolls over. So next year you've got another $5 plus $4,500, you've got $9,500. Literally, by the time a person hit 30 years old, they could have $25,000 in that health savings account, and it's their money. Now, they can't go out and buy a car with it, but when they start having, when they get married, they can use a percentage of it to make a down payment on a house, or their kids get ready to go to college, they can use a percentage of it to help pay for college, but they can't use it all, so that it accumulates over time, so that when they get to that point when they need that knee replacement, or they want to buy long-term insurance to help cover, assisted living or whatever, they've got it. It becomes truly a savings account. On the just in general, for the general population, people, if they want to get their health insurance from their employer, they can. And if they leave their job, one of the key parts of our reform that's already plan's already on the table by the Republicans in Congress, is if they leave their company, their insurance goes with them. If they want to buy their own health insurance outside their company, they can do it, and they'll get a tax credit, individual credit up to $1,400 a piece. So if it's a family of four, you're talking about $5,600 in tax credits to buy a family plan. They can buy it across state lines. They can buy it like they buy car insurance, buy what they need and what they can afford. And then in terms of Medicaid and Medicare, and people who either can't get insurance or can't afford it, will have a national safety net. And the plan that that Tom Coburn, Dr. Tom Coburn, who's also a U.S. Senator from Oklahoma, he and Senator Richard Burr from North Carolina and Orrin Hatch from Utah have proposed, would appropriate about $7.5 billion a year, be divided up among the states, and it'd be lump sum. It won't be a matching deal like we do with Medicaid, to provide insurance for everybody else. What I would really like to see us do is convert Medicaid, and if I really haven't thought through this on Medicare, but on Medicaid, convert it to a health savings account, so that there's an incentive for people to use it in the most cost-efficient manner possible, but also an incentive for them to live healthier lifestyles. And that's needs to be a major focus of any health reform going forward, because, as you know, the biggest problem with healthcare in America right now is diabetes and heart disease and obesity. Yeah, so, which, again, a lot of those people wind up needing knee replacements and having orthopedic issues because of it. But we need to look at this in a comprehensive manner, and we need to look at it from the perspective, again, of a market-driven system that gets, as much as possible, keeps the government out of it, and let the decision making take place between the doctor and the patient, and the patient needs to have a stake in it, and the doctor needs to have a stake in it. And then the last part of this needs to be medical malpractice reform, because we're over-prescribing diagnostics in this country to protect, for the doctors and hospitals to protect themselves from lawsuits.
Right. So. I agree. I mean, you covered it very well, and clearly you have a good knowledge of this. I agree with everything you said. I mean, I think it's very important that going forward that we look at comprehensive reform. I think the status quo was not adequate. I don't think in this country we should have accepted it the way that it was. But again, I think the method and the approach used is not the right way to go. And I think we're looking at a financial disaster down the road, and we're still not covering a vast majority of the uninsured patients, despite the claims. I mean, and again, the ones that are covered still can't afford the care that they need under the insurance that they now have. So it's not really, I mean, it's just, I don't think it's really made a huge dent in the problem. But I agree with everything that you said.
My concern about the Obamacare is that, and you mentioned Medicare and how we're going to deal with that and how the doctors are being reimbursed. There's going to be a substantial cut in Medicare funding to help pay for Obamacare if we don't replace it. And this is over the next 10 years, and it's in the range of, I think it's over $700 billion. And a lot of the senior citizens really didn't understand that. What I want to see us do is move as much of this back as close to the delivery as we can, and get the government out of it, and provide people with a way of saving up in their senior years to pay for the health care that they need. They don't have that right now. Right. And I think the path that we're on right now, especially with how much I think they're going to cut out of Medicare, is that everybody's going to be on a super Medicaid plan. You've got tremendous uncertainty out there in the marketplace, and you've got, we talk about this, that we've created 49ers. Those are businesses, small businesses, who have 48 or 49 employees who will not hire that 50th employee because they don't want to come under the mandates. You've got situations where businesses are making a business decision to pay $2,000 per individual fine rather than pick up the insurance coverage because it's less expensive. And their employees are suffering because they've got subpar insurance now. And they're having huge copays and huge deductibles. So they're not getting health care. And we're headed in the same direction as the British healthcare system, where particularly it's going to be a huge problem for the elderly, because it's like, say, they'll wind up waiting weeks and months for care, and many people, I think, are going to die because of it.
Well, I think it's going to limit access too. I mean, right now, because of the reimbursements of Medicare, many doctors will not take a new Medicare patient. And so, I mean, I think you can ask any Medicare patient, unless they've kept with their doctor, they're not able to get in to see a new doctor if and insurers are now doing economic credentialing, where they're dropping doctors that they deem too expensive, and so patients are scrambling to find new doctors, and it's not an easy thing to do when you're a Medicare patient to find a doctor that's willing to take on another new patient.
Same thing's true of Medicaid.
And it's always been true of Medicaid. Yeah.
And again, going back to this idea of health savings accounts and using that for Medicaid patients as well as for just for the general public that wants it. And by the way, this is not a new concept. There are over 15 million people who have health savings accounts, and there are companies who've really pushed this. But when you have a health savings account, instead of handing an administrator an insurance card, you're paying with a debit card. It becomes a cash transaction. And I've talked with some folks who are pretty smart in the business side of medicine. They say that they think that will generate at least a 20% savings on administrative costs. And it actually helps the physicians. And on Medicaid, then it will make it economically viable for them to see more Medicaid patients. Because it becomes a cash transaction. Right. But I think the best thing that we can do is when we look at reforming healthcare is not just look at it in the context of cost containment, because healthcare is part of the economy. And they count everything that takes place in the medical practice, whether it's something that's needed or something that someone just wanted, as healthcare spending. And I don't have a problem with it being a substantial part of the economy. We've got the world's best healthcare system. We need to have a healthcare system that we can market to the rest of the world. But what we want to do is provide a healthcare system that is accessible to everybody who needs it, and that they can get what they need when they need it.
Well, I support Gary because of basically his background, his knowledge. He's clearly has a good grasp of the facts, and I think he has a foundation. I think he's not a politician. I think he's a very positive individual. He refuses to go negative, and I admire that in a politician, because clearly that's the choice of most politicians today, is to go negative, and I admire that. I've known of Gary and Gary for almost 20 years now, and only know positive things about him. And I think, in terms of healthcare, I think that clearly he knows the facts, and I think that he would be a great representative for this district. I think that it's important for the healthcare professionals to vote, because, again, the direction of this country, both from on the healthcare and other issues, I think we're going in the wrong direction in many ways, and I think we need to put people in that have a strong moral compass and sense of character to combat that, and I think he's the right man for that.